Good morning. I'm Brad Summer from the West Cancer Center and Research Institute. This morning, I'll be talking about genitourinary cancers and specifically the management of advanced prostate cancer. Okay, we'll talk about generalist approaches to first metastatic castrate-sensitive prostate cancer. We'll touch on non-metastatic castrate-sensitive prostate cancer, or what is known as biochemical recurrence. We'll also talk about castrate-resistant prostate cancer in a unique setting of M0 or non-metastatic disease. And in addition, we'll talk about some treatment options for metastatic castrate-resistant prostate cancer. Okay, first and foremost, this is a critical pathway for prostate cancer. In general, as we know, the prostate cancer growth and progression is driven by androgen receptor in the nucleus, and that is bound by dihydrotestosterone that is essentially created by androgen and testosterone that's created in the adrenal gland and in the testes. This is signaled centrally through the hypothalamus to the pituitary gland, sending a signal LHRH, sending to the signal to the pituitary gland to release luteinizing hormone, or LH, that then binds to the luteinizing hormone receptors and drives this cascade. So this AR signaling pathway is critical for the driving mechanism of prostate cancer, and it's on every level of this pathway that therapies are created. The difficulty is that there are side effects with androgen deprivation therapy, and this includes hot flashes, loss of libido, erectile dysfunction, weight gain, sarcopenia, bone loss or osteoporosis, mood disturbances, and cognitive function decline, and a metabolic syndrome, and increased cardiovascular risk. Each of this needs to be watched, managed, and monitored for, and they should be dealt with expeditiously to not create further health problems. Important definitions include high volume disease, which is high visceral metastases or more than 4 bone lesions, or and these are definitions that are defined in clinical trials for metastatic disease. There's also high risk prostate cancer that's 2 out of 3 criteria with Gleason 8 or above, greater than or equal to 3 bone metastases or visceral metastases. And if you had 2 or 3, you're high risk. High burden disease is similar to high volume disease. And de novo M1 disease is the newly diagnosed. In other words, there's no prior treatment for prostate cancer, but they present de novo with metastatic M1 prostate cancer. Very important, and this is a role that APPs can play incredibly well in all of our practices, and that is to put the patient into context with their cancer. And these patients oftentimes are elderly, they have comorbidities, and they, if they're over 70, they have a geriatric assessment could be performed, and probably ought to be performed with the G8 and mini-cog. And to define whether they're fit or whether there's going to be what their general longevity is, what their chemotoxicity score is, and this is something, and their frailty index. And if this can be defined ahead of time and can be charted and put into the clinical context, a very rich decision-making process can be produced. So this is a role that we all can play to enhance the management of our patients. So, headed into castrate-sensitive disease with metastatic disease, the first study to report out benefit above and beyond ADT alone was the 3 studies. There was the GTUG-15, the CHARTED, and the STAMPEDE study, all with ADT plus or minus docetaxel at 75 milligrams per meter squared. The GTUG-15 was 9 cycles, STAMPEDE and CHARTED were 6 cycles, and the STAMPEDE and CHARTED each met the overall survival endpoint, and this became the standard of care. The CHARTED and STAMPEDE were usually the higher volume disease, and this is thought to actually derive additional benefit from chemotherapy in the higher volume or higher burden disease. And you can see that this is in each of these studies, docetaxel is favored over standard of care with hazard ratio of about 0.6 to 0.85, depending on the study, but clear survival benefit with docetaxel. In addition to that, the Stampede and Latitude study were reported out soon after with ADT, also same population, castrate-sensitive, hormone-naive patients with M1 disease, and it's ADT plus or minus abiraterone acetate with prednisone. Abiraterone acetate is a 17-alpha hydroxylase inhibitor, 17-20 lyase. It blocks, and it's given in conjunction with prednisone. Notably, in later studies with abiraterone acetate, there was prednisone was given twice a day, and it was a lower dose, so there's a little bit higher toxicity, which includes hypertension, fluid retention, and hypokalemia. But this study was a positive study for OS and PFS in Latitude, and it became also a standard of care. There's both OS and PFS benefit. The hazard ratio for OS was about a 40% improvement of survival, and about a close to 55 to 60% improvement in progression-free survival. Notable AEs included secondary mineralocorticoid excess that caused hypertension, fluid retention, hypokalemia, mitigated by steroids. And some patients had elevated liver function tests. And additionally, there's cardiac dysfunction. So if somebody has risk factors or already has cardiac disease, this needs to be given with some caution and monitoring and possible in conjunction with cardio-oncology. Additionally, similar study design, there was multiple studies that included additional androgen receptor modulators, and that it was Anzamet, Arches for enzalutamide, and Titan for apalutamide. Very similar study design. Patients either got ADT or they got ADT plus enzalutamide and Arches and Anzamet, or apalutamide in the Titan study, all looking at PFS and Arches, OS and Anzamet, PFS and OS in Titan study, and all met the primary endpoint. Notably, in Anzamet, there was about 45% that had docetaxel in those arms. So that's a study design that included the possibility of a triplet study report out at ASCO this year, showing even in the docetaxel arm that enzalutamide showed benefit as well. So here's a list of all the doublet-based therapies, and that includes with not just ADT, but docetaxel benefit, abiraterone prednisone benefit, enzalutamide benefit, apalutamide benefit. So any of these are possibilities. And then this year reported in the New England Journal was triplet therapy with Aerosens, where patients were randomized to ADT and docetaxel plus or minus darolutamide. This showed an overall survival benefit that it improved, that darolutamide reduced the risk of death by 32.5%. And in addition to that, patients didn't progress to metastatic disease with a hazard ratio of 0.36, very significant improvement in delay to progression to metastatic disease. And in addition to that, with darolutamide, there was a decrease in pain progression, significant. So this added darolutamide to the mix. And in addition to that, it provided the assumption that there are patients that would benefit from docetaxel, and it assumed docetaxel as a prior standard. So there are additional trials that included triplet therapy, and we discussed Enzamet a little bit earlier. But in addition to Aerosens, which we just talked about, the PEACE-1 study also reported out, which was ADT and docetaxel plus or minus abiraterone. And in that case, there seemed to be, with 46 months of median follow-up, there seemed to be an improvement in OS as well. And specifically in a de novo high volume disease subgroup analysis, there was clear benefit with OS when comparing ADT docetaxel plus or minus abiraterone. So when abiraterone was added, it improved OS survival from 42 months to 61 months. Notably, triplet therapy works, but no study has been done to see whether docetaxel is actually needed in this triplet study. In other words, whether you could get ADT plus a novel anti-androgen therapy plus or minus docetaxel. There is no study that has shown that benefit, nor nor likely will there be, but there seems to be the most benefit in patients with higher volume, high risk disease, and certainly in the fit patient population, these are patients that triplet therapy is ideal for. Now the question of radiation to the primary tumor, there were two studies, one at STAMPEDE again, and the HORAD study that essentially looked at patients with M1 disease, castrate sensitive disease, looking at overall survival, whether patients got standard of care with hormonal therapy plus or minus radiation to the prostate itself. So this is with metastatic disease, see whether localized radiation to the prostate would be of any benefit, and slightly different dosing levels. Neither study met primary endpoint for overall survival, but large numbers. However, of interest, there were large subgroups of low burden metastatic disease. And in that low burden, specifically metastatic disease in both STAMPEDE and HORAD, there was a OS benefit at 3 years in both situations, seemingly near identical hazard ratio with a 32% improvement in survival with low burden disease who got localized radiation to the prostate itself. So this kind of ties it all together. So you have essentially, when you have a patient with castrate sensitive disease, you're looking at how fit are they or unfit, are they low volume, high volume, and based on that you can decide ADT alone, intensification with hormonal therapy, intensification with triplet therapy, and whether or not you are going to radiate the primary specifically. Radiating the primary really is only in the lower volume disease. And fit patients, if you're fit and high risk, you might benefit from triplet therapy. If you're unfit and low volume, you might consider a less aggressive approach. So this essentially ties all of that together. Okay, now moving on from castrate-sensitive disease into biochemical recurrence. So they've had treatment for their primary disease and now their PSA is rising. So how do you risk stratify these patients? So Gleason score matters. If it's a low Gleason score, patients are going to do better and their metastases-free survival is going to be a lot longer than a high Gleason score, Gleason above 8. Those patients are going to have a worse metastases-free survival. So if they're M0, they won't be M0 for as long. In addition to that, PSA doubling time is very important. So PSA doubling time under 3, they're likely going to develop metastases very soon versus PSA doubling time of greater than 15 months. Those patients are going to progress over a very long period of time. So that's an important indicator in terms of whether they are going to stay M0 or not. So which are at highest risk? So we already said PSA doubling time under 12 months, high Gleason score, biochemical relapse within 18 months is also a risk factor for relapse, and high initial PSA is a risk factor, as well as several pathological findings like seminal vesicle invasion, extraprostatic extension, intraductal carcinoma. So general concepts with biochemical recurrence, PSMA PET could upstage disease and enable a more targeted approach as it's a lot more sensitive and can also identify oligoprogressive lesions that might benefit from radiation. You got to balance out age, comorbidities, as we discussed before, side effects, high risk features, and patient preference. And in this patient population, specifically in the M0 population, they may benefit initially from intermittent androgen deprivation versus continuous, and it might be acceptable with less quality of life issues. And there's really no data to support novel anti-androgen or androgen receptor access targeted therapy in hormone sensitive M0 disease. And this is a general kind of how prostate cancer works as a modeling. You get initial primary therapy, the tumor volume drops, and then you see PSA recurrence, the PSA rises, and then ADT, they get ADT, they get the testosterone level falls and their disease burden falls, the PSA drops, and then eventually they become castrate resistant, where they continue with castrate levels of testosterone, but their PSA continues to rise, and there's other therapies that we'll be discussing. So in the non-metastatic space, in M0 space, when they become castrate resistant, there are multiple options. And these are androgen receptor axis targeted therapies, which include in the Spartan study, apalutamide, in the Prosper study, enzalutamide, in the Aramis study, darolutamide. Each of these show quite similar survival benefit, and you can see the metastases-free survival is improved about 70% or so in each of these cases compared to placebo. Very significant reduction in distant progression, and they played out with overall survival as well in each of these cases. So each of these are potential standards. They all have different side effect profiles and drug-drug interactions that can be managed, but any of these are options. Okay, and then in the M1 space, where patients now developed castrate-resistant prostate cancer with metastases. So there are then, in that situation, multiple options, and this includes abiraterone compared to placebo. In AA302, asymptomatic chemo-naive patients, there was an improvement by 20% in overall survival versus prednisone alone. In the Prevail study, this was enzalutamide. It also showed improvement in PFS and OS of significance in this patient population. Definitive benefit has 30% improvement in OS with side effects of fatigue, hypertension, hot flashes, small incidence of fevers, less than 1%. So seizure disorder generally should be not given the enzalutamide primarily. Additional options, and this always should be done, is germline testing and somatic testing of the tumor. By doing that, you can identify homologous recombination repair mutations in some of these cancers, and HRD mutations can identify potential targeted therapy with PARP inhibitors. About 23% of patients with CRPC have DNA repair alterations, and about 12% have germline mutations, and the most common being BRCA1, BRCA2, ATM, and CHEK2. This is the PROfound study. It's pre-chemotherapy with CRPC that's progressing on novel hormonal therapy. And there was two cohorts. One was with BRCA1, BRCA2, and ATM alterations. So that's cohort A, and then cohort B are all the other HRD mutations. And you can see listed below BRIP1, BARD1, CKD, CHEK1, CHEK2, etc. All of these are in an all-comer cohort B, and that includes BRCA1, BRCA2, and ATM. And patients were randomized to physician choice therapy, largely alternative hormonal therapy, novel anti-androgen, steroid radiation, or olaparib 300 milligrams BID. Crossover was allowed, and you can see that in cohort A, there was a clear improvement in progression-free survival of significance, about 66% improvement from 3.5 months to 7.4 months, with key secondary endpoints, including improvement of PFS in the overall population by about 50%, and higher response rate of 33% versus 2.3% in the physician choice arm. And time to progression, to pain progression, there was improvement in cohort A by over 55%. And there was a survival benefit in cohort A of about 36%. So clear benefit in cohort A despite crossover. So this should be evaluated in every patient for both germline and somatic mutation. Another therapy would be, it's an oldie but a goodie, is TAX-327, showing benefit of Taxotere docetaxel, which is a Q3 week dose versus weekly versus mitoxantrone. And there's clear benefit to every 3-week docetaxel, with the overall survival benefit, with very known hematologic neurotoxicity, alopecia, nail changes, and fluid retention being the side effects. Additionally, radium-223 is a good option. This is an alpha emitter that's a bone calcium mimetic. The Alsimca trial showed a survival benefit of about 4.5 months with hazard ratio 0.7. and there's a prolonged OS. They also notably needs bone-targeted agent and should never be given concomitantly with abiraterone. There's some hematologic toxicity and diarrhea that's notable, and this needs to be watched for and monitored of the counts. Additional lutetium PSMA radioligand therapy is a new agent that binds PSMA to it uses links PSMA linked lutetium to the PSMA target on prostate cancer cells and delivers a radiation payload and to the cell itself and to the surrounding cells. And this is a VISION trial looking at patients that had prior received one androgen receptor inhibitor and 1 or 2 taxanes, and patients were randomized to standard of care alone, excluding chemotherapy or radium-223 or immunotherapy versus lutetium PSMA, and patients received that, and standard of care was at the discretion of the investigator. There was a overall survival benefit of 4 months, and this enabled FDA approval, but there was some side effects, including some bone marrow suppression and dry mouth were the main side effects. Okay, so there additionally, the TROPIC study showed benefit of cabazitaxel over mitoxantrone after docetaxel, and the Proselica study showed that 20 milligrams per meter squared can be given over just as well as 25 milligrams per meter squared with preserved efficacy but improved side effect profile, with some minimizing the hematologic toxicity, alopecia, and nail changes. But the hazard ratio was 0.7 with cabazitaxel over mitoxantrone, and it's the next line standard of care. The additional options include abiraterone, if not given before, and also enzalutamide, all as options as well. Bone-targeted agents are very important. Zoledronic acid, if patients have bone metastases, zoledronic acid showed less skeletal-related events, and that includes fractures, pain, need for radiation, spinal cord compression. The time to first skeletal-related event was prolonged from 321 days to 488 days. If GFR is altered, doses can be adjusted, and calcium and vitamin D need to be supplemented with notable small risk of ONJ, osteonecrosis of the jaw, that needs to be watched for. Denosumab in prostate cancer had shown even an improvement of skeletal-related events over zoledronic acid, with median time to first skeletal-related event prolonged from 17 months to 20.7 months, slightly worsening ONJ risk, and 13% severe hypercalcemia that could be mitigated with supplemental calcium and vitamin D. So denosumab is the care standard where permitted. So conclusion and take-home points. You have to put all the treatments into overall clinical context, and that includes comorbidities, geriatric assessment. AR pathway is the critical backbone of all therapy. Hormone-sensitive metastatic prostate cancer is treated with ADT and novel anti-androgen therapy plus or minus chemotherapy, depending on clinical context and disease burden. For low burden metastatic disease, can consider with metastatic disease, you can consider radiation to the primary with some survival benefit. With biochemical recurrence M0, there is a role for PSMA PET, and when and how to initiate therapy is questionable, and with the potential for intermittent androgen therapy. M0 CRPC, there are multiple novel anti-androgen therapies that can be given in conjunction with ADT. With metastatic CRPC, check for HRD mutation, very important, germline and somatic, and there's a benefit to olaparib. There are multiple chemotherapy options and hormonal therapy options. Radioligand therapy with PSMA targeted agents and RAD223 as a calcium mimetic are potential options as well. And always remember bone targeted agents with patients with bone metastases. Thank you for allowing me to talk to you today. We appreciate it. Thank you.